So I want to add primary clenching to our list of temporomandibular disorders. It's the one TMD that has no signs and symptoms of a mandible or teeth being messed up. But it's probably the most common of all. Waking with a headache is not unusual to practically all the time. When I ask a patient in the migraine clinic, on a scale of 0 to 10, 10 is the worst pain you can, worst discomfort above the shoulders. Don't give them any specifics. Discomfort above the shoulders. And I do this. Where a 10 is the worst you can imagine, a 0 is you feel fabulous. How many mornings a week do you wake with a 0? You feel fabulous. And then I don't say a word. Don't do it. How many mornings do you wake up with a 0? You feel fabulous. Don't say a thing after that. And they will stutter and hesitate, and the condition will tell them what to say to take you off track. Like, oh, I'm a dental assistant and I have tension. Of course I have headaches. On the days that the days that he makes me work longer, sometimes I'll have a headache. Or, back in 1983, I was in a car accident, so sometimes, well, when I get my worst headache, no. How many mornings a week do you wake up with a 0? Wait. The longer the hesitation and the more rationalization that precedes the answer, the closer you are. What if they admit, like, I don't know, usually I'm, I don't know, maybe 2 or 3, I don't know, maybe even 4. Like, so there. Like 4 mornings, I feel fabulous. And I say, then immediately reverse it and say, so 3 mornings a week you wake up with a number. Now, right now, that condition is trying to convince you to back off and redirect your questioning. So you never ask a chronic headache patient or one you suspect how often they have headaches. How intense are their headaches? Because they love to talk about that. They don't talk about when they don't have a headache. They have to really think about that one. So you wake up with a number. You wake up with a 0. Oh, good. 3 or 4 mornings. So 3 or 4 mornings a week you wake up with the number. Well, what's the average number you might have upon waking? I don't know, 3, 4 maybe. Would it shock you to wake up with a 6? Has that ever happened to you? Would that just be totally weird? No. So you've gone from someone who's going to tell you, oh no, that's not so bad, to someone who would not, to wake up with a 6 would not be weird to them. I think that's really weird. But to that patient it's not. That's normal, that's usual and customary, because they haven't told their neurologist about it yet. They haven't told anybody about it yet, because every time they turn on the TV, there's a commercial for Excedrin, or Tylenol, or Motrin, it's the headache medicine, it's the new migraine things, or whatever. That's part of life. At the supermarket, there's an aisle for headache remedies. So if it's normal, why report it? They don't want to tell you that they're abnormal, because they're like everybody else. They'll be unresponsive to typical medications. They'll have an unremarkable typical history of TMD that no one's been able to help or fix. So here's something from Dr. Dawson's website. After every occlusal treatment of any kind, I ask every patient to close and clench as hard as they can. Why would you do that? Because it does not happen during function. No one chews food like this. I ask them to grit their teeth and grind in all directions. I think we're treating for parafunction. If they can elicit any kind of discomfort, I know I'm not finished, because when I have complete harmony with CR, all the teeth are touching when the condyle is at its most superior position. This is assuming parafunction. He's getting ready for parafunction. He's replicating parafunction. It is impossible for the patient to feel discomfort in the joint. Dentistry is the art and science from here down. We stipulate parafunction. We stipulate occluding. It's our business. The moment you get him to grind as hard as you can, grind sideways, he needs immediate posterior disclusion. Why? He doesn't want a unilateral posterior contact with a translated condyle while elevation is still happening, because it makes your joint hurt. The moment he can get posterior disclusion right now, when someone grinds as hard as they can to the side, he knows the condyle must have dropped down from CR. That's how these posteriors can disclude so quickly. You don't have to rely on the canine. The lateral pterygoid stays passive even during maximal clench. Maximal clench is going to happen on some people. He knows it. You got to stipulate it. What happens during maximal clench to your teeth and joints? Nothing. They're stable. You have posterior support for the joint. It's not going to get yanked sideways because the side that's getting yanked is being elevated still on both sides. Maximal clench means both sides usually. So dentistry is the stipulation of parafunction. You know what the greatest crown in the world to cement is? Upper second molar with no opposing lower molars. Do you love it? You forgot that there was no opposing occlusion when you're delivering it. You don't even remember. And then you do the cotton roll, you get dried out, put the thing in, you take the thing, you say, okay, now close. They go, wow, doc, I don't even feel it. You're like, damn, that lab's good. And you look in there and you go, pfft. You know, you've never seen a crown with a more beautiful occlusal. There's no adjustments. There's no blue dots on it. Wouldn't it be great? Wouldn't it be great if you could put in porcelain veneers on everybody or crowns on everybody and know that their teeth would never touch? How cool! We stipulate they're going to touch really hard somehow, some way. We always think that way. You know, you couldn't say these 3 letters at the Dawson Center 4 years ago. Couldn't say them. Now, he talks about devices as the NTI reduce voluntary clenching intensity to 1/3 of maximum. Clinical observation is impressive regarding rapid relief of muscle hyperactivity on properly selected patients. We did not realize in past splint fabrication that the canine contact does in fact permit this muscle activity for patients who continue to clench even with a perfected occlusion. So the contacting of the teeth is not what caused it. And when he talks about that clench, he now knows. That's so wonderful about Pete Dawson. Unlike some guys who think they know their thing and that's the box and here it is and learn from my box. Pete's world isn't a box. It's just overflowing. He's all getting stuff all the time. I had a chance to have breakfast with him, and he asked some pretty pointed questions, and when I gave him the answer, he went, okay, moved on to the next question. Okay, got it, poof. Now this guy, he's going to know as much about NTI as anybody in a short period of time because it's all taken from what he's been talking about this whole time. It's immediate incisal guidance right now. You don't have to go through the posterior disclusion first. You don't even get there.